Good morning. Welcome, friends. I'm Dr. Malia Jones from Dear Pandemic and the University of Wisconsin at Madison, and I'm here for our weekly Dear Pandemic live Q&A with Dr. Amanda Simanek from UW
Oh,
Wisconsin, Milwaukee. We're going to be tackling pandemic questions from our readers, and we will take questions today about the mutant strain, which vaccine is best, and rumors about asymptomatic transmission. So I'm excited about our question box today. Amanda,
yeah,
how are you?
pretty good. We got snow finally. I can't believe that it took this long in Wisconsin to get snow. It's sort of strange, but
It was a very warm fall and early winter for sure.
we went sledding, so the first snow is always fun in that way before it turns to slush and gray grossness for months. So enjoying that.
We have a neighborhood ice rink that we maintain. There's a group of volunteers from the neighborhood who maintain it by spraying hose water on it, essentially, supported by the Park Service. And the ice rink is already open, which I'm really surprised that we managed to get it open.
Yeah, fun.
Because it's been so warm.
I think the general tolerance for doing things outside is already much higher in our family, which is nice because I think in past winters we would be like, nah, let's just stay home. And, we were out for a few hours. So
yeah.
I think
Nice.
that bodes well, hopefully, for our engagement in outdoor activities over the next months.
Yeah, I hope so. So let's see, we've got questions from readers today. Before we get started, I didn't give a chance to say Happy New Year and give out my big award for the new year. I was going to do this as a Dear Pandemic post, but there were so many other great options for New Year's posts that I didn't get to it. So I want to give out my award. The phrase of the year for 2020 was, "You're on mute."
Definitely. Definitely.
So as a reminder, we don't take our questions cold. We like to look up the answers to our questions to make sure we're giving you the right information. So if you have a question, you can go to our website and submit it in our question box, which is at dearpandemic.org. And while you're there, you can try searching for your question because we have tackled many, 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 many questions already, and your question might already have been answered.
Yes, so you can search by keyword at dearpandemic.org. We also have a heading list of different topics we've posted on that you can click directly on. And I think we have to be close to 750 or 800 posts at this point, because a few weeks ago we were saying 700 posts. So definitely go check out that resource and you may find your answer there.
Yeah. So we are going to take some new ones today, though, and you get to ask the first one.
Yeah,
Go ahead.
I'm asking them first. Okay, so we had a question from Merlin in New York City. They asked, we're hearing that the new strain is 70% more transmissible. I was wondering if you could clarify what that even means, how this figure was calculated, and the caveats, if any, of the methods that were used. So they say new strain and more transmissible sounds scary as colloquial phrases, but I wonder what that actually means epidemiologically. And then another related question to this was from Chris from Salem, Mass. The news is reporting that the new coronavirus strain is more transmissible than the older strain. Does this mean our usual precautions, such as masks, 6 foot of distance, being outdoors, are less effective? What do we need to do to up our prevention game? And, if so, what should we do?
Yeah, we're gonna talk a lot about these issues of transmissibility today. So first of all, some background on the mutant strain. We had a couple of great posts about this. One as recently as last week. We'll drop that link just to give you some background on what it is we're talking about. So I'll explain quickly how this 70% more transmissible figure was calculated. It's a comparison of R values. So the R value, as a reminder, is a measure of how quickly or how many people get infected from each existing case of a disease. And so, for example, if the R value is 2, that means for every 1 person who's infected today, there will be 2 people infected sometime later. that's an R value of 2. So this R value is a really important factor in understanding how fast an epidemic can spread through a population. And it measures, because it measures how steep that exponential curve is, right? It measures how quickly it goes up. So the R value of the standard variant, the old SARS-CoV-2 virus, in London, like in situ, given all of the situation there, was about 1 to 1.1. And so that means that for every person who is infected today, say in 2 weeks, there are 1 to 1.1 more people infected. So that's actually holding pretty almost steady, right? An R value of 1 means that there's not an increase in cases going on. Now, one of the caveats here is that that's very specific to the situation in London, where we have most places closed, schools are open, and there's a particular population density, particular set of restrictions in place. It's been the holidays, so all of that, Now, the R value for the new variant, the subset of people who tested positive for the new variant, is 70% higher. It's 1.7 in London in this particular time and place. So it's not a very precise measure, this 70% higher, but the difference between 1 and 1.7 is a lot. So we do know that it's spreading fast, and we can infer from that there may be biological reasons why this variant is more readily transmitted from one person to another than the previous variant. Why would that be? We really just frankly don't know. There are a number of theories flying around. There's a little bit of evidence for some of them, and those include it might be better at sticking to the cells. A lot of the changes in this variant have to do with are on the spike protein, which is I think of it like the grappling hook that grabs onto your cells to get in. It may be better at entering cells. It might hang around in the upper respiratory tract more than the lower respiratory tract, which would mean that it's more readily expelled. And maybe it produces higher viral loads. So stay tuned. We really don't know why it might be more transmissible. I keep mispronouncing that, transmissible. There's also this information flying around that it may be more common in kids or more severe in kids. And I will say we really have no idea if that's the case or not right now. The news is reporting this widely, and that is a really scary idea. But all we know so far is that of the people who are tested, relatively more of them have been kids. And unfortunately, that's not very informative, because right now in London, mostly what's open is schools. And so it could just be that it's more common in kids right now because kids are the people who are interacting. Or it could be that for some biological reason, it more readily infects kids. We just do not know. There is some, plausibility that the variant could be more contagious or more severe in kids compared to the old one, but we're just going to have to wait for more information to come out here. So to the second question, what do we do about this potentially more transmissible form of the virus? The post that we wrote last week about the mutant strain has this great quote in it. Ashley Ritter wrote this. She said, the best way to stop dangerous mutations in the SARS-CoV-2 virus is to drastically reduce transmission. We're playing with fire when the virus circulates freely in the community, allowing time and new hosts for the virus to replicate and evolve. So, this is one of the arguments for trying to achieve herd immunity through just infecting millions of people is a terrible idea, because the more times the virus gets into someone's body and makes billions of copies of itself, the more potential, more opportunities it has to mutate and change. And eventually it could hit upon a mutation that makes it better adapted to infect more people. So what we need to do about this is just double down on our prevention our prevention strategies, and they are the same strategies that we've been using all along. You know, we've been talking since summer about the SMART guidelines. We should keep our 6-foot distance at least from other people, wear a mask, keep the air fresh, stay outdoors or stay in well-ventilated spaces, restrict the number of people that we interact with, and keep our interactions short. And, you know, there's nothing to suggest that this virus is, you know, those guidelines would be different. They just might need to be a little tighter. This might be a good opportunity for us to look around and see if there's a place where we become lax in our SMART guidelines and tighten up those restrictions. So it is a really important issue, the so-called mutant strain, because some 70% more transmissible or something like it would mean a very steep exponential curve. I mean, that's a big difference. The difference between an observed R value of 1.1 and 1.7 is a big deal. But it's also important because of all these unknowns. We just don't know. Does it mean worse disease course? Does it mean relatively worse disease course in kids? Does it mean a less effective vaccine? Does it mean changes in the duration of infectious period or illness? We don't know. So this is a rapidly evolving situation, and I think we can expect to see more information coming out, and, you know, maybe even some of the things I just said will turn out to not be the case. So stay tuned.
Those are all really good points. And you know, something that I've seen mentioned is that even if there's no increased risk of death with this strain, just more people getting infected will lead to more people getting hospitalized and dying regardless. Right. So tightening up these measures now, you know, it is going to help prevent some of that.
Yeah. And, you know, I think as human beings, we do tend to fall into this, you can kind of get into a slippery slope. You know, if you have been pretty good about, I don't know, your time in the one place that you have to go to, but maybe that's gotten a little more relaxed over time. This is just a good moment to look around and see if we can tighten up those same guidelines. So I've got the next question for you, Amanda. We have a question from Ravana in Montgomery, Illinois, who asks, she's 66 years of age. Is one vaccine recommended over the other one for someone in her age group? And then we got a lot of similar questions from other readers about which vaccine is best, and even might it be better to get 2 vaccines? And I don't mean 2 doses, I mean both of the available vaccines. Yeah.
Yeah. So my short answer at this point would be to get whichever vaccine is available to you first. Right now, the Pfizer vaccine has been rolled out, and we're anticipating shipments of the Moderna vaccine to become available in the next few weeks. So, you know, both of these vaccines have been authorized for emergency use. And if you're up in the queue and have the chance to get vaccinated, regardless of which one you have available. And, you know, the reasons for that are both were tested across a wide range of ages with individuals that had a variety of chronic health conditions, and both in clinical trials had similar side effects. So at this point, and they have similar high efficacy. So at this point, there isn't any compelling reason, you know, for certain demographic distribution of these vaccines to be different, is my impression. And we're putting in the links in a nice article from Stat News, which provides a good comparison of the 2 vaccines and a number of these points. You know, and just in terms, you know, of symptoms, the things that both, you know, vaccines are reporting are kind of the typical immune response symptoms of pain, fatigue, headache, some muscle pain, joint pain, and maybe fever. And so these are common, you know, and these are good. These are indicators that it's working. It's generating an immune response once it's administered to you. There were a handful of reports of allergic reactions with the Pfizer vaccine, but this was really among people who I think already had an anaphylactic reaction or allergic reactions in other instances. So, you know, if you have concerns about allergies or your existing health conditions, you could speak to your doctor directly, but I don't see any reason to get one vaccine over the other at this point.
Yeah, so there are some differences in, the kind of logistics of the two vaccines, but I agree with you in terms of which one is better as a recipient. They're more or less the same. So what would you do if your number came up, Amanda?
I'd be over there in a hot minute.
Yeah, me too. I would take whichever one they offered me. And that'll even include when we have more vaccine candidates available. I'll just
Exactly. So that's, as the months go on, we ideally will have more vaccine candidates that are also potential options. And that is going to help increase our supply and be able to administer the vaccine to more people. And so, from a logistics standpoint, we do have one nerdy girl who has been involved in administering the vaccine, and it'll be recorded which vaccine you get. You'll get instructions with the Pfizer vaccine. The doses are 21 days apart. With the Moderna vaccine, they're 28 days apart. This is going to be recorded by your healthcare provider. And I imagine is going to be, centrally, that data will be collected centrally at the state level or community level. And there'll be a way that they're tracking, which vaccine you got. So at this point, the current, I think, recommendation is that you get the same vaccine in both doses. However, there is, some discussion in the UK in terms of allowing there to be mixed doses. But I think that's not something that you as an individual have to worry about just yet. The people administering the vaccine and your doctor will be sort of coordinating that if that should change.
Right. So quick reminder, we don't take questions cold out of the comment box. If you have a question, you should go over to our website, which is dearpandemic.org, and submit it there. It's just scroll to the bottom of the website. It's under submit a question, I think is the header, and you can submit your question there.
Yeah. Okay. So I think you have the next question, Malia.
I do.
Okay. So Amber from Boston says, I am so excited for the vaccine. I have read that even after vaccination, there is a concern that people could still be asymptomatic carriers. Can you speak to why that is? I don't understand how you could be nearly guaranteed to not get COVID-19 yourself, but still be a carrier to others. Does this differ if you've already had COVID-19?
Yeah, this is a great question, and it is a really important point. So let's talk a little bit about this issue of asymptomatic transmission. There's a difference between having a very low chance of having COVID-19 symptoms, which is what the clinical trials for the vaccines were looking for. It was your chance of having COVID-19 symptoms, or having a very low chance of having COVID-19 infection. Okay, so what does an asymptomatic infection or a low-grade infection look like? That is where what happens is you're exposed to the virus somewhere, it enters your body, it successfully invades some cells and starts making copies of itself. And those copies can be shed and infect other people. But you don't experience severe symptoms or maybe even any symptoms because your immune system is ready to fight off that disease and suppress the infection quickly so that you don't experience symptoms. Now that's what the clinical trials for the vaccine looked for. And so we know that the two vaccines so far are very good at preventing you from having symptomatic COVID-19, right? But that's not the same thing as preventing infection. So we hope that that the vaccines will actually prevent infection by conferring neutralizing immunity, or what's sometimes called sterilizing immunity. Although I, as an aside, I think the term sterilizing immunity is problematic because it gets people all mixed up about what does sterilizing mean. So neutralizing immunity, what does that look like? Now, in this case, the virus enters your body, you're exposed to it somewhere, but it is destroyed by your immune system before it ever enters your cells, which means you are not infected, it doesn't make copies of itself, and it can't be shed and given to other people. So you're never infected. Now, we don't know if the vaccines that are available so far provide that kind of immunity. We just know that they provide the sort of immunity that prevents you from getting really sick. Fun fact, another example of this is that the seasonal flu shot is actually not all that good at preventing you from being infected with seasonal flu, but it's very effective at preventing you from dying of influenza. So lots and lots of people, and I'm sure everybody watching has observed this, lots of people still get the flu after they've had their seasonal flu shot, but it tends to be more, even if you feel really sick, it is more mild than if you had not had your seasonal flu vaccine. And people who've had their vaccine very, very seldom die of influenza when they do get it. And so seasonal flu is a good example of a vaccine that does not provide very good neutralizing immunity. It does prevent you from getting really sick from influenza, though. So it reduces the disease severity. So we don't know yet which of the two diseases, or which of the two types of immunity the vaccines for COVID-19 will provide. I really wish that had been included in the trials, but it wasn't. It's under study now, and I think rumor has it we can expect results on those trials this month. So stay tuned on that one for more info too.
Yeah, and I would just add, what we mean by it wasn't studied in the trials is that the outcome in these trials was symptomatic disease.
Right.
And so people were, tracked as to whether they developed COVID disease,
Right.
not necessarily tested when they were not symptomatic in order to just determine whether they were infected, but had not developed a disease.
Yeah, and so just to clarify, in order to look for asymptomatic infection, the clinical trial volunteers would have had to submit to routine COVID-19 testing with or without symptoms. So there would have been some kind of process of sampling people and taking PCR tests, even when they didn't have symptoms. And that was not part of these trials. So we just don't know if there was asymptomatic infection amongst the trial participants.
But hopefully we'll have more information soon.
Yeah, we do expect more info there. Okay, so last question is for you, Amanda. We have a question from Candy from Indiana who wants to know, she asked, there are Facebook posts going around about the new study with millions of subjects that found that there is almost no almost no asymptomatic spread of COVID-19. What does this study mean?
Yeah, great question. So I guess I'll start just by reiterating the difference between what we would consider asymptomatic versus pre-symptomatic cases. So an asymptomatic person is someone, who never develops symptoms throughout the course of their illness. A pre-symptomatic person is someone who hasn't developed symptoms yet, but will go on to develop symptoms at some point in their course of illness. And before symptom onset, it's very difficult to distinguish between someone who's asymptomatic versus just pre-symptomatic, right? And so that's just one, caveat to start with. In terms of this study, this was a meta-analysis, which means it was a pooling of all studies out there that exist that have, in this case, examined virus transmission within households. And so I think they included 54 studies in this meta-analysis. And they were wanting to estimate something called the secondary attack rate. So this is the probability or likelihood of spreading infection from one person to a previously uninfected person, and in this case, within a household. And they did find that the secondary attack rate was higher among people who had symptoms than among those who didn't. So among those who had symptoms, the secondary attack rate was 18%, whereas among those that had no symptoms, the attack rate was 0.7%. So lower, but not zero, which is sort of something that the headlines have been running with, like there's no asymptomatic spread. We're going to drop a link to an AP News fact checker report on this claim, because one of the authors of the study was interviewed for that piece, and it really outlines nicely that they, have come out to say, no, we did not say that there's no asymptomatic spread. And so you can look at that for, some details from the author. But I do think that this idea that there's a lower secondary attack rate among asymptomatic individuals is not inconsistent with other meta-analyses or with our general understanding that, there seems to be less risk of ongoing transmission among people that don't ever develop symptoms. And then I think what the other important thing to keep in mind is that we still have reason to believe that it's that pre-symptomatic phase leading up to symptom onset where people are most infectious and the day of symptom onset. And so kind of, when you have potentially been exposed and you don't know if you're just an asymptomatic person, not infected at all, or pre-symptomatic, we would recommend all the same precautions to be taken because there's no way to know at that point whether you are capable of transmitting to others. So that's why the safest bet is to operate under the assumption I may have been exposed, so I should wear a mask to protect other people. I should maintain distance to other people. And so it kind of becomes not irrelevant, but it doesn't change very much what we do in practice, whether it's pre-symptomatic or asymptomatic transmission that's most important.
Yeah.
Did you have something you wanted to add?
Well, I was just going to say, I think that this study actually just confirms what we already knew, which, and it's an important study for that reason, which is that asymptomatic transmission, the likelihood is lower, right? That's good news to have that confirmed, because as we were just talking about, the vaccines possibly actually just reduce the likelihood of having symptoms. So that's great news. And that pre-symptomatic transmission, pre-symptomatic viral shedding is really a big problem. And as you said, there's no way to know, I feel fine this morning. Does that mean that I'm not infected at all, asymptomatic or pre-symptomatic? There's no way to know that right now.
Yeah.
So, and we do know that people who are pre-symptomatic, who will get sick in the next couple of days, have pretty high risk of transmitting the virus to others.
Right. So you're best off assuming you could be in the pre-symptomatic phase, So the other sort of just quickly caveats of that the authors noted is that out of those 54 studies, only 4 of them tracked asymptomatic spread. So that was a pretty small sample size, and they acknowledged that caution should be taken in making conclusions about asymptomatic spread from this meta-analysis. Also, that this is a study that looked within households. And so there's a limited pool of people whom you can transmit to, and potentially different circumstances around preventing close contact in a household setting versus if you're asymptomatic and out in the community, carrying on like normal, even though the probability of transmitting to others could be lower, if you interact with more people, there will be more transmission. And so we have to be careful when we're trying to make any inference compared to the household setting versus a community setting in terms of some of this critique that has come out around, lockdown policies were not necessary. It's not necessarily apples to apples in comparison. And so I would, go to check out that AP News link, because I think the author gives some nice context to their findings there, and has definitely come out to say, no, this is not what we communicated or found.
Yeah, Natalie Dean, who was one of the author that you're referring to, was very generous with her time to try to refute these claims about, over-interpreting their study results.
We definitely count her in the Nerdy Girl in Spirit club. So
yeah,
appreciate her taking the time to be so diligent.
Yep. Okay, so that's actually all we have time for today. Half an hour flew by. So if you have a question, I know there are lots and lots and lots of other questions out there. You can go submit it in our question box at dearpandemic.org. And while you're there, you can search for answers to your questions. And in the meantime, thanks for joining us. We will be back here at the same time next week, Saturday at 9:30 a.m. Central Time. And next week, I'm going to be joined by another one of our Nerdy Girl contributors, Dr. Ashley Ritter. And so until then, stay sane, stay safe.
Yeah. Happy New Year.